kind introduction, and yeah, it's Murray, it's not Dr. Ross. And I can tell you, a PhD in economics at Kaiser Permanente is not Dr. Ross. It's you're just the economist. And thank you, Diane, for all you've done for the speakers and the moderators and keeping the conference going. I first came to this meeting in 1998, and a lot's changed since then. Healthcare has changed, policy has changed. What I still think of as, recent policy changes is, oh, that's already been 20 years, I guess, so we should be used to it now. The politics have changed, but this conference has remained successful over that entire period with different, faculty leaders, with different speakers and moderators, and I think a large reason for that is the audience here. There's a level of interactivity that you just don't get at most conferences. For many years, we'd see the same people in the same chairs, and you'd get to know people personally. It's always been a place where people are not afraid to go to the mic and ask questions, and that's really appreciated. And also just to buttonhole speakers at the breaks and at lunch. And that just makes this place a little bit more special. And of course, the venue is gorgeous, and it's, Orange County. This morning, we're going to begin by jumping right into health policy from the start, and I'm delighted to be moderating two people who are amongst the most thoughtful, committed, and effective policy thinkers and leaders. We're going to open with a keynote from Dr. Meena Seshamani. I'll say a little bit more about her in 1 second. The title on the page discusses implementing Medicare drug price negotiation, and yes, we could spend probably 4 hours or a week on that, but she actually is going to talk much more about the broader vision that she has and the administration has for Medicare, engaging in improving equity, improving affordability, outcomes, and care delivery. Meena's bio is in the app, but I'll just mention a couple of things because there's probably no one who can cover more ground and be more appropriate for not just her job, but also today's talk. She's the Deputy Administrator and Director of the Center for Medicare at the Centers for Medicare and Medicaid Services. She's a Hopkins-trained surgeon. She's an Oxford-trained economist. She was a VP for Clinical Care Transformation at MedStar Health in Washington, D.C. In the Obama administration, she was the director of the Office of Health Reform, implementing the Affordable Care Act. She's been a practicing surgeon at Georgetown University and at Kaiser Permanente in San Francisco, yay. And she's a hockey mom. And that's what makes everything else work for her. So, Meena, welcome. We're looking forward to your talk. Please go. And you see Dean Rosen's name there. Just the run of show here, Meena's going to give her keynote. I will probably ask her a couple of questions if I can think of something to make her uncomfortable. And then we'll have Dean up, and then we'll go en masse for questions and audience. Okay, Meena.
Thank you so much. It's great to be here with all of you. I am a hockey mom. I'm also a volleyball mom. I have double travel sports, which means I never know where I am at any given time. And they're both sports that I knew nothing about, so I get to be told every day by my kids, oh my God, Mom, stop embarrassing me because you don't know who the mascot for the Washington Capitals is. Anyway, it's really great to be here. It's great to be back. I've spoken at this conference before, and so it's really wonderful to be back with this group. And the previous time I was thinking about when I spoke here last, and last time I came, I think it was one of the times I came in person was when I was in my role leading care transformation for MedStar Health and kind of walking everybody through a quick tour of Health Economics 101 and why the healthcare market is imperfect and what that means for how we should transform care. And it's really wonderful now to be in this role leading the Medicare program where we can really bring that to life, to really try to make changes to our healthcare system in a meaningful way. And the second thing, as I was reflecting, was remembering how amazing Dean Rosen's slides are at these conferences. So I make no attempt to match him. These slides are very boring, but it's okay, I'll just entertain you with my wit. But I know we're all looking forward to Dean's Academy Award-winning slide presentation next. So as Murray mentioned, I'd like to walk you through, there's a lot that we're doing in the Medicare program, but there is, a rhyme and reason to all of it. And I thought I could, take you on a journey with us as we are thinking about what we want to do collectively for the Medicare program, what is driving us, and really thinking about it across some major buckets of work that we have. The first being, as Murray mentioned, as is in the program, our work on implementing the new drug law, the Inflation Reduction Act. But then it's similar themes that we apply to the work that we're doing to improve the Medicare Advantage program and the work that we're doing to transform care more broadly, not only in the Medicare program, but what that means in the entire health system, because we know that Medicare is often a first mover for changes in the healthcare system. And finally, to round out with a conversation about health equity, as we know that that is a priority for the Biden-Harris administration. And I think for many of us who work in healthcare, especially with the pandemic, it really brought to light a lot of the issues in disparities, how most of health is affected not by what happens in an office visit, but what happens in people's communities. So I thought I would touch on that as well. So I think I'm doing the slides with this. Is this how it works? Okay. So I already kind of walked through some of this. So I'll start with the overall CMS vision. And this really guides a lot of our work in the Medicare program, where CMS really strives to serve the public as a trusted partner and steward dedicated to advancing health equity, expanding coverage, and improving health outcomes. And in order to do this, there are several pillars that we have that we follow. And what I'll do is, as I talk through each of our areas of work, how these are incorporated. So with everything we do, we think about health equity, and where we define health equity as enabling everybody to have a fair and just opportunity to achieve their optimal health, regardless of things like geography, language, culture, sexual orientation, gender identity, race, ethnicity, the myriad of factors that come into play that impact people's health and impact their ability to navigate and interact with the healthcare system. So that's how we define health equity. Looking at how we can expand access to quality and affordable healthcare coverage and care. It's important to us that we engage with everyone as we are doing this work. This is something that's really important to me in particular, because until I took this role leading the Medicare program, I was taking care of patients, as Murray mentioned, at Georgetown, before in San Francisco. And I know all too well that you can put something in a 2,000-page regulation and declare victory, and it cannot make any difference on the ground if people don't understand what you're actually trying to do, and really being able to get ideas from people who rely on our programs or people who are caring for people through our programs. The next pillar is, being able to drive innovation for whole person care, and we'll talk more about that. And in particular, our alignment with the Innovation Center here, so that they can really be the, R&D arm for Medicare and Medicaid, and where things that they test can then be incorporated into the Medicare program if they work. The next pillar is around protecting our program sustainability and affordability for future generations. And finally, it's very important for me leading this incredible team of people who know the Medicare program so well and really are in this work to serve the 65 million people who rely on our programs, that for me, leading the center, creating that positive workplace environment for them, where all of their ideas, as they are meeting with interested parties day in and day out, bringing ideas forward that we're able to bring those to life. So moving now to some of the big areas of work that we have undertaken. So first, implementation of the Inflation Reduction Act. So what's listed on the slide here are various aspects of the law that I can walk through. So the first is, as you all know, and what is the title of this talk, though clearly we have deviated already from that, giving Medicare the power to the ability to negotiate lower drug prices directly with manufacturers. That is kind of one bucket of the Inflation Reduction Act. A second large bucket is the changes that are being made to the Medicare prescription drug program, Part D. And there are several parts of that. Some are already in place. For example, now it started January 1st of last year that people with Medicare prescription drug coverage do not have to pay more than $35 for a month's supply of a covered insulin product. Also, people can get recommended vaccines at no cost sharing. This is game-changing for people. I mean, traveling across the country, hearing from seniors who were spending $400 a month for their insulin, or people there was one woman who was giving money to her brother so that he could get his insulin, or people rationing their insulin. To now not have to pay more than $35 a month is huge. And this is an example of where it's been so important to get the word out. Right now, shingles vaccine used to be, $200, $300 out of pocket. People need to know that now they can go get the shingles vaccine at no cost. Because otherwise, you can't expect a 72-year-old grandmother to randomly think one day, oh, maybe I should go to the pharmacy and figure out if the price of shingles vaccine has changed. So this is why it's so important for us that we are partnering with people to really get the word out about these changes so that people can take advantage of them. Another example of that with the Part D redesign, as we call this bucket, is the expansion that we've made for financial assistance. There is a financial assistance program called Extra Help that through the drug law has now been expanded. We estimate that there are 3 million people in Medicare who are eligible for this financial assistance and not enrolled. So it is so important to let everybody know that if they're having problems paying for their prescription drugs, they could be eligible for this financial assistance. And this is something that in any avenue that I'm speaking, that my team is talking with people, we're trying to really get the word out, again, because there are 3 million people who could be benefiting from this, who may be rationing their prescription drugs because they can't afford it, not realizing that this is a program that has been available for them and has now been expanded. And the last part of the Part D redesign bucket is out-of-pocket cost caps. So starting this past January, when people hit the catastrophic phase of their prescription drug benefit, they no longer pay anything out of pocket, which is the first time in the history of this program that there has been a limit to what people pay out of pocket, because traditionally, people would continue paying 5% in perpetuity. This leads up to January 1st, 2025, when there will be a $2,000 out-of-pocket cap for covered prescription drugs in the Medicare program, which again is huge. There are people who currently spend $7,000, $8,000 a year, and these are people oftentimes on fixed incomes. And so to be able to provide this financial relief is just so critical for our populations. And the third big bucket of the Inflation Reduction Act is around market dynamics. So 2 things here. There is a biosimilar add-on payment to encourage utilization of biosimilars, again, to get more competition in the biologic space. And there's also the inflation rebate, where if a drug manufacturer increases prices of certain drugs faster than inflation, they have to pay the difference back to Medicare to discourage those price increases. So again, kind of the 3 main buckets of the Inflation Reduction Act: drug negotiation, Part D redesign, and some of those changes to the market dynamics. So now what are we doing in terms of implementing, thinking about those strategic pillars that we have guiding our work? Certainly equity is front and center for all of this work. As I mentioned with the Part D redesign, being able to eliminate financial barriers to access prescription drugs is huge, particularly for underserved populations. And it's been so important for us to engage with trusted partners and communicators for communities directly. Not everybody wants to listen to me. My kids certainly don't. And I know that. And so it's really important that we are getting the word out and we're partnering with patient groups, with local community groups. We're working with our administration of community living, with the area agencies on aging, so that they can get the word out, so that we can really make sure that people are able to understand what the benefits are, to be able to navigate, to be able to have their questions answered. Equity also plays a huge role in drug negotiation. So, we put out guidance to describe how we were going to stand up the drug negotiation, Medicare prescription drug price program. And really, front and center in that is being able to enable conversations, data-driven conversations around the benefits that the selected drugs provide. These 10 drugs that were selected, we followed the law. There's a variety of requirements looking at the top spend in the Medicare program. There are various exclusions if the drug is, an orphan drug for rare disease, if it is a blood or plasma-derived product, if it is low Medicare spend. We followed all of those requirements in the law and came up with a list of 10 drugs that really treat some very common conditions, like diabetes, blood thinners, heart disease, cancer, rheumatoid arthritis, and other immunological diseases. And how we are approaching negotiation is really saying, okay, we want to understand what are the benefits that these drugs provide. Do they meet an unmet need for people? Do they impact different populations differently? This is also an opportunity, because these drugs have been on the market for at least 7 or 11 years, to really understand the impact that they have for communities in the real world, not just in a randomized controlled trial. So being able to incorporate the perspectives of, well, if a drug is easier to take, does that lead to improved health outcomes? So that is something that could be considered. And so we've really embraced this opportunity to drive the conversation around how drugs serve to benefit people in the real world, in their communities, thinking about how it can enable them to live healthier, more productive lives. What impact does it have on other aspects of the healthcare system, and really being a call to data, not just from drug manufacturers, but also from the public. We held 10 patient-focused listening sessions where we could hear directly from healthcare providers, caregivers, patients about the benefits of these drugs, the barriers to taking these drugs, to be able to hear directly and include the patient voice. So I think, the way that we're trying to implement this negotiation program really is incorporating those pillars that I mentioned around health equity, thinking about unmet need and how these drugs impact different populations. Innovation for whole person care, really, again, thinking about making sure that we can have the innovations for the cures and therapies that people need being affordable and accessible, and that we're rewarding meaningful innovation, because we all know there is a difference between a breakthrough drug and a Me Too product, and how do we together figure that out and get data to help us. And how we are promoting sustainability and affordability and really driving more transparency and dialogue to enable the market to work better. So that is all underlying our implementation of the negotiation program as well. So that is Inflation Reduction Act in 5 minutes or less. So, similar themes moving to other aspects of the work that we're doing. So, transforming care. Again, my role before I came to Medicare, I led community health, case management, geriatrics, palliative care, all the primary care managers, and really bringing that to bear on, healthcare really is not just about seeing a person in a 15-minute office visit, assigning an ICD-10 code, an E&M code to claim, for claim that you can bill for, and then sending someone on their merry way. And I know that many of you, probably through the work that you do, have examples of where using that kind of framework means that people fall through the cracks. So, leading community health in my prior role, just one example. We had a woman who kept getting readmitted, coming into the ED. She came into the ED 17 times in 3 months for chronic obstructive pulmonary disease exacerbation. So we assigned a community health worker to her who went out to her house and found that her electricity kept getting shut off, so her nebulizer wasn't working, so that's why she kept coming to the ER and then having to get admitted to the hospital. So the community health worker helped to fix her utilities issue, and lo and behold, she stopped coming into the hospital and was able to be healthier. And so it's just one of many examples of how we need to change the way that we're thinking about healthcare so that we are actually addressing the myriad of experiences that are impacting someone's health. And as just through this story you see, this really brings that innovation for whole person care, health equity, and also sustainability, where we want to spend the healthcare dollar in a smarter way. So some of the things that we have been doing in this front, we, for the first time ever in the history of the Medicare program, have created payments for community health integration, where community health services are part of an overall care plan, paying for care navigation, so principal illness navigation. When someone has a serious illness, that there can be a payment for helping that person to navigate care. Another new payment, first of its kind, paying for caregiver training. I mean, I think it goes without saying that all of these incorporate a much broader perspective of what it takes to care for someone and to keep them healthy, to consider health-related social needs, to consider the needs in a community, so that that healthcare dollar can be spent in a smarter way, because you can keep people healthy rather than they fall through the cracks and then they come in, when they are sick, and enable us to achieve our health outcomes. We also have been increasing payments for primary care, longitudinal care, behavioral health. We increased payments for psychotherapy. We created payments to better integrate behavioral health with primary care. And we also created add-on payments for primary and longitudinal care to acknowledge the complexity that's associated with creating that more trusted long-term relationship with someone, which we know ultimately means better care and better outcomes. Also on behavioral health, we've made some of the biggest changes to behavioral health in the history of the Medicare program, including creating a new benefit. Previously, Medicare had, acute psychiatric hospitalization, acute psychiatric day hospitalization, and then maybe you can see your therapist one day a week, right? We created a new intensive outpatient program, thanks to congressional action, so that there is more intensive outpatient options, so people aren't left in that gap. We also, for the first time, are now able to enroll licensed marriage and family therapists and licensed mental health counselors into the Medicare program. And we've already had thousands of healthcare providers enroll, which, as we all know, behavioral health has tremendous equity and access issues. And so this really gets to the heart of some of the issues with behavioral health by expanding the types of providers who can enroll in the program. And then the last area here in transforming care comes back to our bucket on, market dynamics and sustainability, where we're looking to increase transparency, increase competition. So we are enforcing hospital price transparency regulations. We have strengthened them in a variety of ways, including requiring standard ways in which Hospital prices are posted. They have to be posted in a standard location on hospital websites. There is a set defined time frame within which hospitals must come into compliance. And the transparency and competition also comes through in the next bucket that I'm going to talk about with Medicare Advantage. So, moving to Medicare Advantage, this absolutely, is now 50% of the Medicare program and is really an important part of the Medicare program. And we want to make sure that when we are partnering with private health plans to deliver Medicare, that it is all towards those, shared goals that I have been talking about. So, in the same vein of thinking about equity and access, we've done a lot of work on cracking down on misleading marketing practices. In fact, in the latest Medicare open enrollment, we rejected more than 1,000 misleading television ads. And we know that these ads are particularly targeting vulnerable populations, people who are duly eligible for Medicare and Medicaid. So really trying to, again, bring all of those pillars to the work that we do. And we also know that people need to choose the option that works best for them, for their health needs, for their financial needs, because otherwise they could get stuck. We heard this from healthcare providers where they're calling their doctor to make an appointment and their doctor says, well, actually you changed health plans and I'm no longer in your network. And the person says, what? When did I change health plans? I didn't know I changed health plans. So it's also an access issue, it is a quality issue, it is a coverage issue. So really trying to do work to limit misleading marketing practices. Plans cannot use, and their brokers cannot use the Medicare logo in a misleading way. We've also proposed changes to agent and broker compensation to try to minimize financial incentives that could otherwise steer people towards a plan that is not best for them. Also, on access, we heard a lot about prior authorization. We did a request for information on the Medicare Advantage program and got more than 4,000 comments. Prior authorization was something that we heard from absolutely everyone about, from patients who said, I can't get the care I need and this is way too confusing, from healthcare providers who said, jumping through all of these hoops to get my patients the care they need just creates all sorts of unnecessary burden and work and frustration, and from health plans who said we need clearer rules of the road of what we need to follow. So we made significant changes to prior authorization where we said to health plans, if there is a coverage decision in traditional fee-for-service Medicare, you have to follow that. You cannot do anything else. If there is not a coverage decision in traditional Medicare, then you can have some prior authorization or utilization management, and it has to be publicly available following well-established clinical guidelines. It has to be reviewed on at least an annual basis by clinical leadership, and other common sense things like if somebody changes plans, that prior authorization follows them for at least 90 days. When you do a prior authorization, it is for the duration of the course of treatment, because we heard a lot of provider calling up saying, yes, my patient still has this condition and still needs to have this treatment, and they have to go through the whole process of prior authorization again. So really thinking about common sense changes here to increase access. We have done a lot in the sustainability bucket around Medicare Advantage payments to improve payment accuracy. We updated our payment model, risk adjustment model, to more current data years, moving from 2014 to 2019. We moved from ICD-9 to ICD-10, and we also took a look at, for the conditions, which conditions actually correlate with higher costs, because ultimately the purpose of risk adjustment is to channel money towards those enrollees who cost more so that plans don't cherry pick. So, doing some of that recalibration. We're also doing a lot of work in quality. This is also in the transforming care bucket, where we're seeking to align quality metrics across our programs. Again, when I was leading care transformation at a health system, we had this big spreadsheet of the 500 quality metrics that we were being held accountable to for all these different payers, all these different programs, that just drives everybody nuts. It doesn't necessarily, drive change. So really creating a more core set, and yes, there are adjustments on that based on what is appropriate for populations, and there's an opportunity, for example, for the Innovation Center to be able to test new quality metrics, but to really be able to streamline so that you can mobilize change on the ground. We've done a lot of work in health equity here, and this is aligned with our accountable care organization work in traditional Medicare and value-based care to really reward care for underserved populations. So both in Medicare Advantage and in our accountable care organization program, the Medicare Shared Savings Program, when quality metrics are met for health plans or healthcare providers that are caring for underserved populations, there is an additional financial reward. So really trying to further that across our programs. And I mentioned transparency with hospital prices, and transparency is here as well. We recently put out a request for information on data and transparency in Medicare Advantage, because we know that through supplemental benefits and other avenues, there's a lot of innovation happening, but we need to understand what that is. And is it working? Is it helping? Is it changing health outcomes so that we can all be part of this continuous learning together? We've also made proposals to increase the data-driven nature of the program. For example, through the bid process, if a health plan is going to offer a supplemental benefit, they have to demonstrate how that improves health outcomes as part of the bid process. Because again, being able to enable caring for addressing health-related social needs, we know is important for health, and we want to all learn together on what are the most effective ways to do that so that the dollar is spent in the most effective way to really drive improved outcomes. And I think between the transforming care bucket on the fee-for-service side and Medicare Advantage, we really want to drive more and more towards these holistic care models. We have a goal of having 100% of people in traditional Medicare in an accountable care relationship by 2030, whereby their healthcare provider is accountable for cost and quality of care. We have now about 50% of people in traditional Medicare attributed to one of these accountable care organizations. And we've been making a lot of changes, like the things that I've mentioned, being able to bring this care transformation into the very chassis of provider payments so that people learn how to do population health. They can hire that community health worker or partner, with that community-based organization, so that then enables them to take the step into some of these more advanced care models, and learning more on the Medicare Advantage side, for example, through this request for information about how these models are working on the Medicare Advantage side as well. And I think the last bucket, again, just talking about health equity, and I've already touched on many of these, where we really are thinking about how we can reward excellence for underserved populations, both through our accountable care organization models, through Medicare Advantage. We've also taken a successful model from the Innovation Center and scaled it in the Medicare program by providing upfront investment dollars to small providers in rural and underserved areas that they can use, and they're using it for things like hiring community health workers, hiring staff, improving their health IT, so that they can provide this more holistic care in an accountable care organization. And we know from the model that was tested in the Innovation Center that this is a good investment, because providers in rural and underserved areas, they knock it out of the park on quality metrics, and they end up saving more money than what that initial investment was. So it really is a win-win. As I mentioned, we're really trying to instill the lessons learned from these care models into the basic chassis of the Medicare program by paying for community health services, care navigation, et cetera. And on the Medicare Advantage side, we really are doubling down on requiring Medicare Advantage plans to have language access, culturally competent care. And to come back full circle to the Inflation Reduction Act, as I mentioned, health equity really is front and center in all of the work that we're doing across those buckets that I mentioned, the drug negotiation, the changes to the Part D benefits, and the changes to the market dynamics. So that was my whirlwind tour of the Medicare program. But hopefully, it enabled you to see how, really our vision of driving health equity, innovation for whole person care, really improving the market dynamics, sustainability, competition, and access and quality really underlies all of the major buckets of work that we are undertaking.
So before we let you take a seat, I just wanted to ask a couple of questions. One is, you mentioned the Innovation Center. So Liz Fowler, who heads up that group, has spoken at this conference a number of times. And can you do 60 seconds on how your group and CMMI, that's the Center for Medicare and Medicaid Innovation, how the two groups interact?
Yeah, Liz and I have made a very concerted effort to work very closely together. And I will say, in part, my experiences leading care transformation in a health system, one of the things that despairs me the most is when you have the pilot graveyard, where you test something, it works, and then it has nowhere to go. And so we really are thinking about the Innovation Center being that R&D arm where they can do model tests with an eye towards, if it works, how can it be scaled in the Medicare program? So we give them ideas. Hey, here is this issue. Is this something that you all can test to see what we should do in the Medicare program? And vice versa, where the example I gave, this advanced investment payments, the Innovation Center did a model test, the ACO investment model. This was when I was in HHS back in 2016. It was very successful, and then it went nowhere. So coming back now, leading the Medicare program, we said, hey, this model demonstrated that, especially for smaller providers in rural and underserved areas, if you give them some investment dollars up front, they make really good use of that money to drive improvements in care, and they end up saving more money than what you spent, so we scaled it into the Medicare program. Similarly, the payments that I was talking about, community health services, care navigation, these are all concepts that have been tested in various CMMI models that now we are scaling into the Medicare program, and we're continuing to engage with CMMI about other things that could also be scaled, like as they are evaluating ACO REACH, for example, as they have been working on making care primary and other primary care models. So that's kind of how we are working together.
Thank you.
I don't know if that was 60 seconds, though.
We'll call it 60 seconds. 60 Dean Rosen seconds. So I have two questions that are sort of face and obverse of the same question. You were talking about partnering around, improving health equity, and that's an area that has some natural supportive constituencies, whether it's patient groups or civil rights groups or however you want to characterize it. For others of your goals, they may lack a natural constituency for support, or in some cases, we'll call it drug pricing, there may be an actively hostile constituency. What do you do in those cases? How do you partner?
Well, I think ultimately, and I'll give the example of the Inflation Reduction Act. I have been very clear. I have had, the day the law passed, whatever it was, August 16th, picked up the phone, started calling people, started having meetings, health plans, providers, patient groups, drug manufacturers, and I said, look, the law has passed. My job is to implement it. And this is one of the things with the Medicare program, right? You have Medicare law that then within the structure of the Medicare law, we have administrative authority to issue regulations. So the law is at like the 50,000-foot level. Our regulations are at the 25,000-foot level. And then it's how things actually play out on the ground, which I experienced firsthand being a healthcare provider. And so, in all the conversations that I've had, I've said, look, my job and my goal is to implement the law in the most thoughtful way possible. I think everybody can agree, this is hearkening back to my Health Econ 101 that maybe some of you heard, the last times I came to this conference, that there are ways that the healthcare market can be improved. And I think everybody agrees on that. And so how do we try to improve it? Where are there areas that we can make sure that we are driving continued improvements in the program? And that's really the spirit with which we have engaged all stakeholders. And I will say that's the same with care transformation. It's the same with Medicare Advantage. At the end of the day, people generally go into healthcare because you want to help people and you want to be able to innovate in a way that's going to serve and is going to have impact. And so really being able to enable that and have a dialogue and engage everybody accordingly.
So my part B to that question is that one of the challenges with change is that it requires change, either in reporting or behavior or income. And at sort of the 30,000-foot level, what have you found most successful in engaging and getting people interested in change?
Yeah, well, there's a joke somebody told me recently. There is only one person who likes change. Does anybody know who that is? It's the baby with the dirty diaper. But I do think it is bringing everything back to all of our core, right? That ultimately you want people to be healthy. You want to be able to make a difference. We all know that there are cracks in the system, and so it is important that we do think about ways we can improve because, I think everybody wants to improve. And with that, it's important to really get ideas from people on the ground. I could just sit in my office and try to come up with things on my own, and maybe they'll be successful, maybe they won't, but instead, like just yesterday, after I flew in, I did a behavioral health roundtable, I did a healthcare for the homeless roundtable, and I heard from people who are directly taking care of people in these issues. What are your ideas for what we can do to make things better for the work that you want to do? And given the things that we have done, are there ways that we can task you with making sure that the policies that we're putting into place actually have the impact that we would all want? I think it really is that everybody has to be engaged in this. Change really is about we're all a part of the problem and we're all a part of the solution.
Well put. Thank you. So Dean, I can hardly see you in the light there. I was panicked there for a minute. Where's Dean? Dean Rosen is familiar to many of you if you're a frequent flyer with this conference. He's been here for a number of years, and he's going to take again one of his classic looks at the national mood and politics of healthcare and the policy agenda beyond Medicare. Dean is a partner with Mehlman Consulting, a firm in Washington, D.C. that represents and educates clients sort of across the healthcare verticals. He's held a number of high-ranking positions in the U.S. Congress, some of which he disavows now because of the legislation he helped write. But he was with the House Ways and Means Committee and the Senate, what's now the Senate Help Committee, and with a chief advisor to Senate Majority Leader Bill Frist. And prior to all of that, I think it was prior to all of that, you were at the Health Insurance Association of America and also at a law firm, so you've been on both sides of the desk as well. So without further ado, Dean Rosen.
Thank you, Murray, and thanks to everyone at UCI. I really appreciate the opportunity to be back. Okay, Meena, you did such a good job. This is forward. Okay, good. It works. But thank you very much for having me back, and Steve and Hope, thanks for putting on such a great conference, and Diane for all your work, and Murray, it's great to be back with you. I think you enabled a few of those laws that we don't talk about anymore, and your past positions as well. So, and I think what Meena said at the start of her talk is that I have to use slides because I'm not as witty or entertaining as her, which is totally true, as you'll find out in a minute. But we do, you'll find it later, even though we're on kind of different sides of the political aisle, we worked in different administrations, we do share the hockey parent thing, which we can get into in our Q&A if anyone wants to do that. So Meena did a fabulous job, and honestly, it's an honor and a privilege to be here and a little daunting to follow her. Because she covered so much of the administration, I'm going to focus mostly on what's happening in healthcare in Congress. But to do that, I wanted to take a bit of a giant step back first to put into context what's happening at the federal level from an elected standpoint. I know you're going to hear from great folks on and experts on state policy in a moment. But I wanted to step back and do that because I think putting some of the changes we're seeing, which are enormously disruptive in our political and our policy environment, in the context of the economic, societal, and technological changes that are taking place in our broader society and world, I think explains a lot more. And so I want to do that and then talk about the Congress and some of the fiscal fights and other things that are roiling this 118th Congress before getting into a little bit of the healthcare, and then we'll conclude with a little bit of a fun look ahead, because there's always an election around the corner. Now, Meena made a vague reference to Academy Awards, and I haven't been at the conference for a couple of years with COVID and travel and virtual and all that kind of thing, but after speaking for a couple of years, what she was referring to, who's been at the conference, who's your first time here? A lot of first times, okay. So after I started speaking for a few years, it occurred to me that one of the cool things, I was a film major in college, was that this conference takes place a week or so before the Academy Awards in California. So for kind of a East Coast guy to be in California was sort of cool. And I decided that what I might do is talk about health policy and politics thematically during that year, and I've continued this by framing some of the debates we're having in the context of the Academy Award nominated pictures. So I'm going to...
One year it was La La Land.
Yeah. Yeah, well, that was one of the best. Some of them aren't as good this year. But I thought as we talk about some of the societal changes, enormous technological changes, and some of the political explosions we're having, the first theme was Oppenheimer. And so, again, I want to step back, and I'm going to go pretty quickly through some of these. So the nation and the world are facing persistent and growing problems, and we see that with the growth out here, I don't have to tell you, in California, of natural disasters, of illegal immigration, debt, overdose, inflation, gun violence, hate crimes, inequality in our income and our geography. And by the way, I think, Diane, all these slides are available somewhere in the app, so when I go quick, you can go back and study them. But the issue when you think about some of these things, maybe other than the national debt right now, is that they're things that people live with and feel every single day. Think about, the inflation at the gas pump, or think about the gun violence in our neighborhoods, or, back to the drug overdose deaths. I read a statistic yesterday that I think half of all Americans know someone personally, a family or friend, that's experienced a drug overdose death. And then you've got increasingly, I think most Americans, I saw this sort of interesting article just last week based on a 2022 survey of households. The middle class is defined statistically as being between a certain income level. But when pollsters sort of ask people, what does it mean for you to be middle class, which I think in part I define as the American dream. People aspire to be middle class. They come up with these 6 things. I have health insurance. I have steady employment. I can save for the future. I can pay bills without worrying. I can afford emergencies, and I can retire comfortably. When you stack that waterfall up, only about 1/3 of all Americans can achieve all of those things. I was surprised that 90% or more said that they have health insurance, but we know part of the economic problem is that even if you have good health insurance, you've got gaps in payment and out-of-pockets. But this is another real personal thing if people feel these changes. And then in addition to some of these massive changes, you've got divisions that are growing across the country. We are increasingly a red and a blue nation, and all of these trends are changing and getting worse. More women than men vote for the Democratic candidate. These are back to the data just before the last, or aligned with the 2020 election, but these have only grown worse if you think about divisions. Increasingly, urban voters have always voted for or leaned Democrat, but increasingly our rural counties are growing more and more Republican. And race and education, probably the most interesting statistic, if you look back, is a lot of people think, oh, the Republicans, those are sort of those wealthy, well-educated white voters. Well, it turns out the white voters without a college degree increasingly are voting in huge percentages and numbers for Republicans. So we're getting more and more divided as a nation. And then when you look at these issues, gas prices, fentanyl deaths, immigration, what's happening on the world stage, this is a question that gets asked every year by the NBC News, Wall Street Journal, and other people. Are we heading as a nation? It's a simple question for simple minds. Are we heading in the right direction, or are we on the wrong track? The last time the country felt like we were on the right track was when George W. Bush was president, sort of in the aftermath of 9/11, and we're at historic lows or highs right now, with only 73% of people feeling that we're on the wrong track. And this number is, I'm sorry, Meena, gotten worse for the president. This is 2023, in the first few months of 2024. But it's not just the president, it's how we feel overall about the mood of the country, so you can see that. And then the last thing I'll mention in sort of this broader picture is, and you see this sort of playing out every day, you know, a lot of the old rules and norms and things that we sort of grew up with. We've got faith in the church. We've got faith in our medical professionals. I know we've got a lot of physicians here. But when you look back at 2019, which was the year before the last election, and 2023, which is the year before the election we're about to have this year, you can see that all of these major institutions and trust, from physicians, which are the highest, but still fell 9 points, to the Supreme Court, to higher education. You look at what's happening in some of our elite universities, getting roiled by the debates over the war and the events in the Middle East. Mass media, church, religion, presidency, and at the very, very bottom is Congress, which we're going to talk about in the next section. And that didn't think they could get any lower. The late great John McCain, senator from Arizona, used to say that with numbers this low, they would even be lower if they didn't count paid staff and blood relatives. So, you know, this is where we are. And I don't have a slide on it, but the other thing we see in our own lives is just the impact of technology. And the last time I came to the conference live, you know, I think there was just the beginnings of Uber. You know, now everyone's taking a Lyft or an Uber or something else from the airport. But I mean, this has transformed our lives, and the way we not only communicate with each other, but dissect our news and see the world is increasingly fragmented by the growth of technology. But trust is down, and trust is down in Congress. And I thought the perfect movie to frame some of the dysfunction and some of this low level of support for Congress was Anatomy of a Fall, which, by the way, is a terrific movie with subtitles. I saw it last weekend, but tremendous acting. I highly recommend it. But look, this is what's happened. This has been an historic 2023. We had 15 votes to elect a speaker, and then 3 months later, 8 Republicans joined with all Democrats and threw that speaker, Kevin McCarthy, out, California boy. We then took 3 weeks, as Republicans, to elect a new speaker. And now he's kind of walking on eggshells and may not be the speaker the next time we're back here, or even sooner than that. And you look at these historic things that are happening. The impeachment last week in the House of Secretary Mayorkas, the second cabinet secretary ever and the first since 1870 to be impeached by the House. So we are living in historically disruptive times. My first point about society, economics, trust of institutions, technology, and that is affecting Congress. We've also seen, I'll talk about it in a little bit, these extremely close elections that have gone back and forth between the parties, and you're all experiencing that. We hate the Republicans, they're doing a terrible job, let's put the Democrats in. We don't like them either, let's throw them out and put Republicans in. But in some ways, what's happening with the Republican caucus in the House, and I want to focus there in part because I want to make sure I'm fair and balanced, but it's where by just objective definition, and I'm sorry for my Republican friends and colleagues, is the source of most of the dysfunction, and it's a numbers game. Look, these are the historic majorities going back to the 1920s in Congress. The blue are Democratic majorities, the red are Republican majorities. And you can see that where Speaker Johnson is now is he's got 6 votes. And right now with the special election that took place in New York after we ousted George Santos, the Republican majority in the House of 435 members is 2. He can only lose 2 members on any single vote. So, you know, what we know is small numbers empower minorities, empower factions, and that's why it only took 8 folks to vacate the chair and basically kick out Kevin McCarthy. But before that, Speaker Boehner and Speaker Ryan, who were threatened by the Tea Party and the Freedom Caucus, which is the Tea Party kind of evolved into the Republican Freedom Caucus, they had larger majorities. Now, one thing I want to note on this slide, you look back and you see that in the early 2000s, Republican Speaker Denny Hastert had 7 Republican votes, pretty narrow margin as well. Nancy Pelosi had only 9 votes. The difference in part was clearly experience. The difference in part was also clearly that you've got some folks in Congress now who spend more time raising money on social media because they're blocking rules and blocking votes and anything else. But the other big factor that people don't talk about a lot, but has been a factor with Pelosi last time, is that you have a president in the first term. In Hastert's case, he had George W. Bush in his first term. There's a lot of uniting around, you know, let's get stuff done for President Biden, let's pass the Inflation Reduction Act or whatever. You don't have that now with divided government, and that in part is some of his problem. And you look at the outcome here, these are public laws enacted by Congress by year, going back to the 1950s. Now, the Do-Nothing Congress, Harry Truman ran against the Do-Nothing Congress back in 1947. I think the only person in Washington who was around then was President Biden. But that Congress passed 900 laws, 900 total laws. In the first session of the last Congress, the House and the Senate passed 34 laws, a historic low, and they passed 5 this term. So you can see what happened with most censures, the expulsions, the speaker votes, is that legislative activity cratered. And where are they spending their time? They're spending their time on oversight, both parties. Oversight really is an overdrive, and I think for those of you, a lot of our clients, not just in healthcare, but across many sectors, are feeling the heat of this. And the challenge is not only the heat of it, but when you look at the fact that you've got a Republican House that has an oversight committee that's on overdrive, a judiciary committee, and a lot of committees that are doing oversight, and a Democratic Senate, you can be a CEO who gets called in one day for not being sufficiently aggressive on things like DEI, and you can be called in front of the House the next day for being too woke. And this is what's happening, is a lot of folks are trying to navigate this, again, this division, but a lot of time spent on oversight. Now, the other big thing we're spending a lot of time on is that, and I want to talk about some of the spending issues which sort of frame up the congressional health issues here in a moment, is we're having huge fights. Again, there's about 40 or 50 members of the Freedom Caucus, and these are some of the most prominent ones. We can do a quiz afterwards if someone can name these members, but we are spending a lot of time, again, the minority of the House, feeling like we've got to have really tight controls on our spending. And we've got to add to our spending bills policy riders on things that are kind of red meat and red potato issues for the Republican Party, banning transgender care in certain facilities, taking away money from certain educations. Those things may be really good ideas, and I have no doubt that these members of Congress feel really strongly, but the fact is that you are not living in reality if you are a minority of the House, and the House is one of 3 bodies that's political that makes decisions, and the other 2, the presidency and the Senate, are controlled by Democrats. You cannot get everything done. And because Speaker McCarthy couldn't get everything done, and because he had to make some rule changes to win over the speakership and empowered some of the more conservative members of the Republican caucus. That's why he was ousted by just 8 members. But the biggest sort of battlefield of their fights have been overspending. And by the way, we're not talking about Social Security or Medicare or Medicaid. We're talking about the 25% or so of the budget that's discretionary, mostly discretionary spending. So these are the Freedom Caucus members, a little divorced from reality, like this movie, which I think was, may get an award or two. I think they were snubbed for the best director. But a couple things. Why are we having these funding fights? Well, historically, this happens a lot. You look back to World War I, when we had the Spanish flu and a war, World War II, and then the global financial crisis when President Obama was president. We often respond to these crises with significant federal spending, and then what often happens, as you can tell from this chart, is that we have a little bit of austerity kind of hangover in the aftermath of it. And we have had an historic last few years with COVID, unprecedented times. So the government spent, and we've avoided, I think by definition have achieved a soft landing, but national debt is up 46%. Federal spending was up 31%. Inflation reached a 40-year high. And so part of this backlash is intensified by the historic times that we live in. And it's why we are approaching a March 1 and March 8th deadline, and we're at, I think, the 4th time when we could face another potential government shutdown. It's been averted the last few times, but we could face another one, and we're 5 months into the fiscal year that they're trying to fund. The president is about to send up his spending bill, as I understand it, in early March for fiscal year 2025. We haven't yet passed fiscal year spending for 2024. Before this debate, the Senate, there's 12 annual bills that fund every agency of the government, including Meena's and HHS. The Senate, up until now, has passed only 3. The House had passed 6, and none of those had passed the same bill that went to the president. So they keep punting and saying, let's have a continuing resolution or sort of a stopgap spending bill. And the next deadline is, guess what? Next Friday, March 1. And they still don't have an agreement yet, but this is what was in it. I won't go into the details. And there were a handful of healthcare extender programs that were included along with it, things that had to get passed, like health center, community health center, teaching health center money would have run out, a special diabetes program. Meena talked about some diabetes drugs, but a special Medicare program. Delay in disproportionate share cuts to the states, done mostly on a bipartisan basis, sort of was included. And all of these healthcare kind of extenders will expire March 8th. They did this in kind of 2 tiers. 4 bills will sunset next Friday, and the other bills will sunset about a week later. And we will see next week if we're going to have a shutdown. And healthcare will be at the center of it. I got some news this morning about where things are, and so I do want to segue here to healthcare and then to politics in a minute, but I want to drill down a little bit on healthcare. Couldn't find a great movie theme this year, except as I was thinking about, okay, it was kind of Murray's question about, to Meena about, you're sort of fighting with, Meena's not fighting, she's such a nice person, but you're going up against a lot of stakeholders who don't like change other than their diapers, and change is hard. And we're fighting over in healthcare an increasingly small piece of the pie. There are many, many more things that need to be funded or that people want to have funded than there are dollars available to pay for them or appetite to raise taxes, particularly in a Republican House. And so I thought a little bit about health policy winners and losers as being poor things. And this is a little bit of where we are, and I'll go through it really quickly. This is sort of my 118th Congress in healthcare in one slide. So this March bill that will sunset not only 2/3 of the government in a couple weeks, but all the health programs, there are things that will probably be tacked on to that if that bill passes. And they're there in the list of the March Health Package: Community Health Center extenders, Support Act reauthorization, which is substance abuse, pandemic all-hazard preparedness authorities, and National Health Service Corps, and other things. They've been talking about a whole bunch of things that don't need to become law and are not extended, like increased transparency, codifying some of the things that this administration and the last administration did, pharmacy benefit manager reforms to try to pass through more directly savings. I'm told as of this morning that because of the overall conflicts they're having on the bigger bills, and because of these differences between Republicans and Democrats, that a lot of that's probably going to fall by the wayside. Everything changes by the minute, but I think by this weekend we'll know more. But I think a lot of those other changes will not be part of it. I do think physicians will get a little relief from Medicare conversion factor and an APM bonus. It sounds like that's going to be included, but that's it. We've also got, if we get through March, a bunch of expiring provisions in the fourth quarter of the year to September and December, including all the very popular telehealth flexibilities that are also, quite costly to do. Hospital at home demonstration project, which has been very popular. And then you've got a bunch of issues that are kind of being teed up for the longer term. A physician payment caucus in the Senate that's just come together on a bipartisan basis. It's an expensive problem, but nobody's happy with the current Medicare physician payment structure. I know Meena hears a lot about that from stakeholders and says it's the law's fault, not my fault sometimes. But AI in healthcare, AI is a huge issue, getting a lot of attention in Congress increasingly, and I've noted here some hearings and some groups that have come together on AI. Supply chain, drug shortages, drug pricing, and mental health would be another one. Step back and look at just some of the emerging themes outside of the bills as I've thought about it at, again, maybe 20,000 feet. When you look at a lot of the bipartisan bills, whether they pass in March or they don't, I think they're coming, at least this Congress or next Congress. Greater transparency for everyone in the system. We want to know, not just Medicare Advantage, what are your prices, what are you doing? Greater oversight for everyone. Right sizing and better targeting a number of subsidies. So the 340B program come under scrutiny. I talked about PBMs, Medicare Advantage plans, the proposal before the administration right now would be effectively some reductions in payments. Greater payment accuracy, so site neutral payments for hospitals. Federal government shouldn't reimburse. Why should the federal government reimburse more, and why should a patient pay more out of pocket if they get the same kind of service at an outpatient facility versus an inpatient facility or vice versa? The hospitals do not like that, but there's been a lot of support at least to do something incrementally. Meena mentioned the oversight of health plans and administrative simplification from prior authorization to surprise bills, mental health parity, and other things. And then I don't think we're going to get into a lot of coverage debates other than maybe this Medicaid dish protection, but next year, the Affordable Care Act enhanced subsidies will sunset, and we will, telehealth I mentioned, so coverage is another theme. So I tried to put, again, on kind of one slide, what is out there. Now, I'll go through this next thing really quickly, and then we'll get to politics, and then we'll conclude, and we'll have time for questions. But I did want to sort of underscore this kind of poor things theme here. I represent in my practice almost every stakeholder. We at Mehlman consult with and lobby for major health systems, health plans, innovators. We don't do branded pharma anymore because of the drug pricing policy fights between payers who we represent and health systems, and branded pharma are hard, but generics. Every one of my clients thinks that Congress is totally out to get them. And you probably feel that pressure too. And you know what? There's a little bit of that. I just looked at a couple of these. If you're a hospital or health system, how many people here, I know there are a lot, work in a hospital health system or affiliated with a hospital health system? So, last year and this year, negative press, focusing on nonprofit care, patients are being sued. There's mounting fiscal pressure. Because the trust fund is running out of money. You've got more organized opposition, people who are researchers and independent folks like Arnold Ventures or Family USA consumer groups who don't like these misalignments in payment. Anyone know who this criminal is? Willie Sutton, who famously said, "Why do I rob banks? That's where the money is." And the biggest piece of the federal pie from a provider standpoint are hospitals. And again, this just shows there's mounting pressure. But if you're a drug company or an innovator, you can do the same thing. There's negative press. Drug makers are throwing the kitchen sink to halt Medicare price negotiations. They don't like a lot of the things that Meena's doing, despite the fact that she's super nice on Medicare negotiation. There's bipartisan opportunities and interest in patent reform and insulin pricing, which has been put in place, as Meena noted, in Medicare. They're talking about extending the private sector. And if you're a health plan and insured, the same thing. Bon Secours is suing Anthem over unpaid claims. There's bipartisan not only regulation, but legislation that passed overwhelmingly that would go farther than the regulations on prior authorization reform. There's oversight of marketing and so-called ghost networks where there's inaccuracies in the Medicare Advantage and there's hostilities to PBMs, which are increasingly vertically integrated with plans. So you could do this for physicians and others too, but you can see. And the fact is that when you look at the projected growth, this is the latest study from the Congressional Budget Office. This was where Murray used to work and toiled in many years in Washington. That pressure is going to continue to mount because net interest on the debt and healthcare programs, including Medicare, are growing faster than any other piece of the pie. And we've been having these huge fights in Congress that we just talked about and that you've probably been following in the news, again, over non-entitlement programs. But these challenges are going to even grow, and it's going to be an issue, probably not for this president or this Congress, but for the next president. And so with that, I'm going to just conclude with politics for a couple minutes here. And I thought about the fact that we have two of the oldest, I think the oldest presidential candidates in history running. And be honest, there are big parts of the Democratic Party and the Republican Party base that are not thrilled with these candidates. But by March, we'll know, and I think the stars are aligning, that we will have a rematch between President Trump and President Biden, or as you would call it in the Academy Award parlance, the holdovers. Now, this is, again, I'm trying to do things simply for my Republican pea-brain mind in one slide. What I see this election is about. On the left, the case that the Trump folks are going to make is, aren't you angry? Aren't you angry about increasing crime? Are you angry about border and the fact that we've got all these migrants historically, all these woke CEOs and other things that are enabled by all this health equity stuff? Inflation is higher. The president may say he's bringing down inflation, but gas prices are still high and the price of milk is still high. This is the Republican case that they will prosecute, which is one reason for sure that former President Trump told Republicans, don't go along with this bipartisan border deal that Republicans and Democrats in the Senate negotiated. I don't want to take that issue off the table and give President Biden the ability to sign something and say he's fixing things at the border. And the case I think that President Biden will make against President Trump is, aren't you afraid? He's going to take away your abortion rights. He's going to take away your Medicare. He says he's not going to do anything in Medicare, but boy, a lot of people around the president talk about it. Look at January 6th, threats to our democracy and pulling out of NATO and threats to the world stage. So again, in some ways, I may be overly simplistic, but these are a lot of the issues. This is the polling from earlier this month, the NBC News Wall Street Journal. And what you notice is that not only is the President Biden's approval rating at historic lows since we've been polling, but President Trump is moving ahead on a lot of the top issues. I mentioned border security, and you can see these margins in 2024, where President Trump is ahead of Biden compared to 2020. So he was plus 16, President Trump, on the border issues back in 2020. He's now plus 35. And that's how dealing with the economy, 55% favor President Trump versus President Biden, plus 22 compared to plus 10 before. Crime and violence. Being competent and effective, this is going to be a huge issue on both sides of the campaign, but particularly, underscored by the special counsel's report the other day, improving America's standing in the world. And the president's issues that he's leading on, protecting democracy, which is why he's leaning into, January 6th and taking away your rights. And the president's going to sort of militarize, use the military to go to the border and the issue of abortion and reproductive rights, clearly an advantage. And I mentioned the fact that women voters and suburban voters earlier are generally with the Democrats. But this is the battleground right now. What you don't see here is health care as an issue. It's usually a top issue, but I think it's going to play out in micro ways as part of as part of the broader economic issues, is people do feel insecure, and I think you're going to hear more about drug pricing as you go forward. You've got Liz Hamill later on a panel from KFS who specializes in this, so I'm not going to try to do her job. But one reason the president's conclude. Yep, okay. One reason the president's doing badly is we're having a soft landing, but people don't feel it. The election map favors Republicans in the Senate. The Democrats are defending more seats. The House is a bit of a coin flip with more Democrats, with more Republicans running in seats that President Biden won. And California and New York, but probably California, are really in some ways going to decide the House outcome. These are the seats that the Cook Political Report says are leaning one way or the other or at risk. And I'll go fast and just conclude here. It's going to be a close election, as Murray said. And the fact is that 2025, with all this uncertainty, these close elections that go back and forth, is going to bring with it huge issues that we're not going to solve, some of which we've mentioned here, but immigration, energy, healthcare for sure, all of the Trump tax cuts on the individual side, $2 trillion expire next year. So we've got a lot on our plate. And with that, I'll conclude and look forward to your questions. Thank you.
We have a little over 10 minutes for questions, and I think we have people who are going to be running microphones up and down. So if you have one, wave your hand, and somebody will bring a mic to you. Yes.
Thank you, Meena and Dean, for a sobering look at our healthcare in terms of political arena as well as Medicare and Medicaid. So I have a question for you, Meena, and maybe Dean can touch on it as well. You both kind of touched lightly on the AI component of healthcare. I'm a practicing physician, and believe it or not, AI already exists and is already implemented in our medical group as part of help us to provide better care and more efficient care. There's a cost to this. And so far, the reimbursement and the investment in this technology for acquisition as well as implementation has not come into fruition. For instance, right now, we implement an AI assist dictation for physician in the medical group. That's at the cost of $800 for a licensing fee per physician, and we are actually asked to bear that cost. So as far as Medicare investment into infrastructure, and even Dean in the political arena, is this on the roadmap in terms of helping us not just payment reimbursement kind of a bump, but like actually bucket that going to help us to acquire these AI technology and help us to become more efficient and create access and deliver better care. So what do you say about as far as how can you help us to afford this technology to become better doctors?
Thanks. Is this on? Okay. Thank you for the question, and I'm glad that we're bringing up AI. So this is an area that we are looking at. In fact, we did a request for comment on software as a service. Like, should it be considered a service? How could it be paid? And I think the flip side of it is also something that you touched on in terms of thinking about where AI can be helpful and maybe where there need to be guardrails as we're thinking about, issues of patient safety, et cetera. And so an example on that end, as I mentioned with Medicare Advantage, the work that we have done around creating more guardrails and policies for prior authorization. If there is going to be a denial with the prior authorization, it has to be reviewed by a provider with relevant clinical expertise. So, you could have algorithms that are, compiling big data, but there has to be an individual level analysis for that individual patient with the decision by someone who has relevant clinical expertise. So that's some examples of how we are thinking about this issue.
Question is for Meena. So a couple of years ago, Medicare introduced a new contracting model called DCE, Direct Contracting Entities. So could you update us on how well that has been working, and have you been seeing increased uptake by the provider community to participate in this model?
Thank you for the question. The direct contracting model was an innovation center model, which actually got moved into ACO REACH, which is a new accountable care organization that, in particular has really been focusing on how can we bring more like safety net providers, FQHCs and, safety net providers into some of these more holistic care models. So testing things like incorporating the social framework of a patient population into the financial benchmark that you create, like doing a health equity adjustment and other things. So that model is ongoing, and that's something that, as I alluded to when I was speaking, we in the Center for Medicare are definitely collaborating with the Innovation Center to see what are lessons learned, what maybe worked well that we should think about incorporating into the larger Medicare Accountable Care Organization program.
Hi, Meena. So I lead care delivery transformation for Anthem Blue Cross, and the biggest barrier that we experience is that the connectivity in the different EMRs. And I feel like the government hasn't done much to connect the EMRs and the data or health information exchange across different providers. So how much ever we talk about health equity, if there is no visibility into the patient's current status to another provider, we're always going to be behind. So is this something that CMS is looking towards, I don't know, some incentives about making sure everyone is on a similar platform so there is better EMR connectivities?
Yeah, that's a great question. So our Office of the National Coordinator for Health IT has been implementing something called TEFCA that I'm blanking on what the acronym stands for. Do you remember what it stands for? Okay. Yeah, but basically to create more of that interoperable platform that not only would enable better communication among EMRs, but then also enable you to bring in other sources of data, say to connect better with census data, social needs. So I think that is work that ONC is doing. I will say from the CMS perspective, again, to give the example of prior authorization, we recently finalized a regulation to require interoperability and increase streamlining of the process for prior authorization as well, so that people don't have to go to multiple places. And we're also looking into ways that we can make data delivery easier and more streamlined for some of these care models. Because again, to your point, if you have to, as a provider, go to each individual health insurance portal and put in information to get data, that is feedback that we have heard. It would be very helpful to figure out a way to make it more streamlined, and that is also something that we are looking at.
I would just add quickly, I think TEPCA, whatever it stands for now, could be a game changer in the sense of it is a national platform where essentially people are pledging to join. I think part of the challenge is that not every one of the big EMRs has yet pledged to do so. Some have, others have not. And the other challenge is just that not every provider, particularly small and safety net providers, can afford to make those changes. And it probably is an area where it's going to take a combination of maybe some grants or some regulatory incentives and relief to try to get everyone on it. But I do think TEPCA could be a game changer.
Sure. Dean, I think the large number of slides you had could be summed up with kind of
Not that bad.
one way or different ways. Big nuclear cloud, perhaps. But this is going to be a question mainly for Meena, but if nobody's tweeting here, I hope you can answer this, but you may not, and Dean might have to take it up. Let's assume that Trump wins. What changes on the ground at CMS? Does the word equity get white marked out of every single document? Does the IRA go into neutral? Because sometimes the change at the top doesn't really affect what's happening at the bottom, depending on the way that Congress has written the statute. What's your best guess for what really changes That's why, yes.
Oh, I'm much more interested in Meena's answer. Well, you know, I think in part it's a great question because I think it's unclear because this, you know, president hasn't campaigned on other than talking about repealing and replacing the ACA. We don't have a lot, and this isn't going to be an election that's kind of fought out, I don't think, over the details. Plus, President Trump was in favor of some form of drug negotiation. So I think part of the challenge is that there's going to be a push and a pull between the president and his instincts on things like entitlement reform, not wanting to do it, and where the heart of the Republican caucus is and the energy is in the Republican caucus, who are going to want to do things like that and who are not going to want to repeal again or take on repeal of Obamacare. But down to that level, I think it's hard. I think the equity and DEI things do become changed. Although there's interest in rural health, I think some of those get reframed. I think some of the initiatives do continue, though. I think there's support across the political spectrum for some of what CMMI is doing, even though Republicans don't want to talk about that as linked to the ACA. I think, frankly, if you look at how Republicans are reacting, there's a Paragon think tank report, which are a lot of the folks who served in the former Trump administration and may serve again on Medicare Advantage. It was not overwhelmingly in favor of let's do everything the plans want to do. So I think there will be some changes on some of the social issues. I think there'll be a change in prioritization. I think you'll get a lot of people there that, unlike this administration, have not had as much experience in government and plans. And I think there'll be a lot that stays the same.
I also want you to join me in thanking Meena and Dean, who along with flying across the country to be here, also just on a day-to-day basis have to live and work in this chaos, and they do it with good humor and good sense, and they get things done. So thank you.